All right, should we do this? Are you guys pumped? That's like the most I've talked in a long time, so let's make this like somewhat more interactive, okay? You don't have a clicker, do you? Awesome, thank you. All right, so one thing that we forgot to make slides about, and I was thinking this as I was driving down, was stones. And I don't remember when I was in medical school getting like a lecture from anybody about stones. And stones are like a huge part of clinical practice for everybody. And that's another airplane thing that you'll run into, someone who's having a stone. So what's the issue with stones? Kidney stones of and in themselves are not a problem. They are not an emergency. It's not something the patient needs to be seen about right away. It's pain related to stones and the consequences typically from obstruction. So the first thing is someone incidentally has a kidney stone, non-obstructive, seen on a CT scan for other reasons. That's not probably a source of any problems. It needs to get worked up. What is a stone that's causing a problem? A stone that is passing down into the ureter or obstructing at the ureteropelvic junction, causing the kidney to swell up, and you're getting all this fluid, and then you're getting that horrible renal colic that people liken to worse than childbirth, the worst pain imaginable. Those are the circumstances that interventions are necessary, and what needs to be done? We need to alleviate their pain. We need to make them feel better and then do an assessment. When do we have to do something urgently, like a procedure, a surgery? This is not necessarily a test question, but this will be good in your mind just to understand when you get a call from Aunt Ruth at 2 in the morning about her kidney stone. All right, so reasons surgical intervention or come to the hospital. Pain that's not controlled with oral medication, and so outpatient narcotic pain medicine is what we're oftentimes using. Pain's too bad. Okay, you got to come to the hospital. We need some morphine. We need some kind of intravenous medication to get pain relief. Fevers or infection proximal to the stone. We have a stone in the ureter and the patient has a temperature of 102. You're suspecting obstructive pyelonephritis. You think there's an infection behind that stone, and that is going to progress very rapidly because there isn't drainage. That's quite an emergency, can progress to sepsis and multi-system organ failure very, very quickly. So fever and stone. That's obstructing stone. That's a second reason. Nausea and vomiting and just being so ill, can't keep down fluids, risking going into renal failure just from all the nausea, vomiting, and being ill. Concurrent significant medical problems. An immunocompromised patient, someone who has severe diabetes, you're just really worried that they're going to get very sick. Okay, come to the hospital, let's at least monitor you or something like that. And what's our typical interventions? We're thinking things like putting in stents, decompressing that system, not treating the stone, treating what that other issue is, the obstruction. So we're thinking a nephrostomy into the back to get drainage and then ultimately deal with the stone, but we're not going to run in and treat a stone in a septic patient. We're going to want to get drainage. We're going to want to get them better and stronger, and we're going to put a stent up there or something to that effect, okay? Cool. Okay, so we're going to talk about prostate stuff in this talk. Lower urinary tract symptoms, that's just LUTS, L-U-T-S. This is so much in medicine is going to be, I guess, what do you call these, acronyms? And I remember when I was a third-year medical student, you'd look on a chart and you'd say, what the heck is this? Because it's all abbreviations, And so here's one that we, as urologists, love using, lower urinary tract symptoms. And understanding this distinction, irritative versus obstructive, is going to be valuable in terms of framing things in your mind. Instead of being all over the map, you need to start categorizing conditions, categorizing disease processes so you can fit it and understand it. So when you're talking to a patient, you're not just getting a list of symptoms. You're understanding where are they on the spectrum of diseases, and that's going to impact how you're going to treat them. You're not going to just list, okay, he's got 17 symptoms. You're going to say he's got a lot of irritative symptoms of his prostate problem, or he's got a lot of obstructive, and that's going to be manifested, or that's going to be addressed with our therapies. So, irritative. Think about, oh, I got to go to the bathroom all the time. I'm getting up at night. I'm having a lot of urgency. I'm rushing to the bathroom, and I might leak if I don't get to the bathroom on time. That's going to be your irritative LUTs. Then obstructive LUTs. What are obstructive LUTs? That's pretty obvious. You're standing at the toilet, and these are going to be men, obviously, right? They're going to be standing there and straining and pushing, slow stream, hesitancy, starting and stopping stream, sense of incomplete emptying because they're obstructed. Dribbling afterwards so that they can't empty out and then it just keeps dribbling and dribbling, spending a long time in the bathroom. Conditions that we're going to think. We're going to think of obstructive issues. I neglected to put just simple urinary tract infection here too. So BPH, prostate cancer, prostatitis, which we'll talk about it, infectious or non-infectious. Irritative things within the bladder like stones, neurogenic bladder, urethritis, urethral stricture. That's another form of obstruction, a fixed obstruction like prostate, which needs to be distinguished. Basic evaluation for a patient with prostate symptoms, typically over the age of 40. The value of doing a digital rectal exam for prostate evaluation in someone under 40 is pretty limited, and it's probably going to make the patient not come back and see a doctor for a long time. So you probably don't have to do a digital rectal exam on the 23-year-old who says they're peeing a lot. So digital rectal exam. What's the prostate supposed to feel like? I don't know if you guys have done had a male model or whatnot. I typically say something firm and consistent, about the size of a walnut, and I use my finger as a marker. I say the tip of my finger is about 10 cc's or so I kind of get an idea. The average prostate, 20 or 30 cc's. What are we looking for? If we're looking for malignancy, we're looking for something that feels like a knuckle, something really suspicious and hard, pretty obvious. A really tender, and you don't have to push hard. I mean, you push hard, they're not gonna like you, and they'll say bad things about you on Yelp. But just gentle contact on the prostate, and if they're really uncomfortable and it's boggy, you're thinking this might be infected. So other things that we're going to be looking at, urinalysis. I mean, obviously, we're going to look at the urine and see if they're infected. Someone comes in and says, oh, I'm having a lot of problems peeing. If you don't check the urine, just rule out an infection or bleeding or something like that, that's just very negligent. So PSA, lots of controversy, and we'll talk about that a little bit, but I don't want to make this the PSA lecture. You poll 100 different doctors in 100 different specialties in America, and you'll get different arguments for and against PSA. The basic backdrop, I don't even want to talk about it. We'll get onto it in another slide. What's an ultrasound? So we're thinking doing ultrasound evaluation just if we want to get a better volume measure of the prostate. Transrectally is effective. This is showing This is showing a needle biopsy, so a transrectal needle biopsy for suspected cancer. That's going to be a rare circumstance. It's not part of the standard workup, but just showing you generally what we're doing. Okay, so this is a representation of BPH. Again, so up top on this slide up here, on my right-hand side is showing the bladder and a cross-section of the prostate. So this is bladder up here, urethra, verumontanum, and kind of an open, normal-looking channel. So BPH, you're going to get this transitional zone, this anatomic zone that surrounds the urethra. It's going to be enlarged and typically compressive. The best way I try to explain it to patients is imagine your urethra and your prostate is surrounding it. It's like stepping on, if your urethra is like a hose, it's like stepping on the hose. So that makes them understand the notion of some of the obstructive symptoms. The irritative symptoms are a little bit more complex because our bodies are not a faucet and a hose. You know, we're going to have a lot of different things going on, and our bladder is going to react to an obstruction. Our bladder is going to become more muscular. It's going to start dealing with it, and that's going to translate into the other symptoms. But just a simplistic way to approach it would be just think of this central zone or this transitional zone hyperplasia and the obstruction. Typically, you're going to see BPH in people over the age of 40. You're not going to, anyone with urinary symptoms before 40. I mean, it's very uncommon that it's going to be a prostate issue. I'm talking very, very rare, and the value of doing a rectal exam, again, is limited. And it's going to become more common as guys are getting older. As they get older, we don't exactly understand why, but there is so the normal anatomy of the prostate at puberty, it gets kind of to the adult age of about 20, 25 cc's, stays silent for a while, and then around age 50 or so, it starts growing again for a lot of patients, and we don't understand exactly why. I talked about you're going to get this mechanical obstruction and other things that are going to sometimes present when it's really progressive. Urinary retention, that's kind of like end stage. There's still things that we can do for this, but it takes us from the category of just symptom relief to now we have to talk about catheters and surgery. And generally, we don't want to get there. We want to address a patient's problems before they get to urinary retention because they're not going to get back to normal after we address it then. Bladder stones can form, just the stasis of old urine in the bladder, or if they have a kidney stone that comes down but can't pass through the urethra, it just sits there quietly and just grows with time and time. And I've taken out bladder stones the size of fists in patients that just thought, oh, I thought I had prostate problems. I had to pee a lot. It irritated me. It's literally the size of a fist. And so what is that mechanism of urinary tract infection? Just think of stasis. And another analogy that I like using, and it helps patients, is think of a toilet that doesn't completely flush. If there's stuff that's left behind, over time, it's going to get yuckier and yuckier, and that's where you're going to get infections from. The urinary system stays sterile because that urine that's made from the kidneys rapidly progresses down to the bladder, and typically within a few hours is all passing out of the body. If you're never completely emptying, then you're always having some leftover urine, and that's going to be the source of these problems. So it's not uncommon to have some degree of residual urine in the bladder as you're getting older, but when it's getting more and more significant, you're getting at risk for these other problems. And we talked about the workup, the urinalysis, and the PSA. My PSA plug will be this, though. The arguments against using PSA were asymptomatic populations. So someone coming in with complaints of urinary symptoms, there's a strong need to include this in the workup. Those arguments saying that PSA overdiagnoses prostate cancer and whatnot, that was supposed to be an asymptomatic, just screening population with no complaints whatsoever. There is some value in checking the creatinine and bladder ultrasound and kidney ultrasound if you think this is a progressive bad disease, if there's been urinary retention. Initial workup, that's way overkill and unnecessary. What do we do when things are getting really significant? We do testing like urodynamics. What's urodynamics? It's basically kind of neuromuscular testing for the bladder. Someone says, I can't pee. They have a catheter in that was placed in the emergency room. My question is, first, why can't you pee? Let's see, okay, you have an obstructive prostate. If I fix that obstructive prostate, am I going to get you peeing again? Am I going to get your bladder functioning? And it's not so simple. Sometimes there's been such a degree of decompensation that alleviating the obstruction does not relieve the urinary retention. So urodynamics is a way for us to test that. We can use like pressure catheters in the bladder, fill up the bladder and say, try and pee, and don't cheat, don't use your abdominal muscles, and we can measure this too. And we can see if they can generate a detrusor contraction. We can see if there's actually muscle function in that bladder. Even if they're not emptying at all, we can see, okay, if we alleviate the obstruction, you've got some muscle still working in that bladder, we can get you peeing again. So that's a urodynamics. And here's You put this in for me, thanks. This is kind of showing what we're doing. So we're kind of looking at a patient's flow rate and how much effort they're taking to void, how much muscle is being used. The bladder muscle is called the detrusor. And how does a muscle become so dysfunctional? For patients, the way I usually describe it is that chronic overdistension of your bladder had resulted in a lot of the actin and myosin fibers just getting stretched apart, all the muscle fibers just being pulled apart. And even though you were peeing before, and acutely you couldn't, it was an end-stage bladder. And you were using a lot of cheating tricks. You're using your abdominal muscles, and you probably weren't even voiding that well. You're holding on to a liter and just voiding, 100 milliliters. The bladder was pretty much done. And that's, our urodynamics will help us with that. It's rare. It's rare that we have to put our face so close to the genitalia, but it happens sometimes. But that's showing a flexible cystoscopy where we're looking in the urethra, get an idea of the obstruction. So we can basically look through here, see if there's any kind of stricture, looking at the prostate to see if there's obstruction, a wide open channel, and you say, well, I don't think the prostate's a problem, and you're not voiding. I think based on the changes I see in your bladder, I think your bladder's in dysfunction. We need to do some further workup. I mean, are we dealing with a multiple sclerosis or something like that? And so this is very helpful, just looking at the anatomy to confirm the diagnosis. Symptoms do not necessarily translate exactly into the diagnosis. So still using our minds and kind of doing testing and not just kind of saying, oh, you have this symptom, you have that problem, because you're 50. When do you want to get a urologist involved? We'll talk about that in a sec. So what's the basic approach to this? So this is a good one because Dad's going to say, hey, you're in medical school and I get up 3 times at night to go pee. What are you going to, how do I fix this? And you go, I'm in medical school. What the hell do I know? Well, this will be your answer because you will get hit with this and you'll get like some weird uncle at a party that'll come up to you and say, you need to put a scope inside me, and you say, I'm in medical school, I don't put scopes in people, but that's too much information, sorry. First I'll say to the patient, okay, so what is the complaint? What's the problem? I mean, even in a primary care setting, okay, I'm getting up a lot at night to pee. Well, what's your fluid intake at night? I mean, do you have to have like, 2 beers after 8 o'clock? Or have you ever considered just cutting back on your fluids? If our one goal is just less nocturia, maybe we reduce nighttime fluids and see if that makes a difference before we kind of go down the big workup. Or, I've got a lot of peeing in the morning. When I wake up, I go every hour. Well, okay, and the rest of the day you're okay? How much coffee you drink? Well, I have 3 or 4 cups of real strong coffee. Well, coffee is a pretty strong irritant for the bladder, and it's a diuretic as well. So why don't you try decaf and just see if that makes a difference? Before what I do to you, and you'll be on chronic pills or therapy, and there's going to be side effects, and that's usually enough for him to say, okay, I'll try it. What about okay, I'm leaking. I get this urgency. Well, how often do you go to the bathroom? I don't know, when I get the urge. How often? I go twice during the day. Well, why don't you just plan every 4 or 6 hours, go to the bathroom before you get to the point that you're so overfilled and your bladder's just can't deal with it and it's having an uninhibited contraction and you're leaking. Why don't you time your voids and see if that makes a difference? So these are just kind of lots of things that can be done. That dribbling, I'm dribbling now after I go pee. Why don't you just, instead of standing there and rushing or pushing or straining, just focus on relaxing, letting the detrusor muscle gradually get that last bit out. So just spend a little bit more time in the bathroom, and that may be enough. Or we can go down the medication route. That's not helping enough. So 5-alpha reductase inhibitors. I think I talked about them before. So Proscar and Propecia, which is the small dose for hair loss, and Avodart. So these are going to be inhibiting the conversion of 5-alpha reductase testosterone to dihydrotestosterone, which is the bioavailable testosterone for the prostate. So consequently, you're going to see a shrinking of the prostate over time. You're starving the prostate of one type of testosterone. Works really well. Takes a long time, 6 months. And if the prostate's not the culprit, they're not going to get any relief, and you had them on a medicine for 6 months. So it's better to confirm that the prostate's really the culprit, and the next medicine will usually help us in that process. Risks of this medicine, a small percentage of people will, about less than 10%, have a decrease in libido and consequently sexual function. I didn't put it up here. There's a warning that this medicine may be associated with high-grade prostate cancer. Way too long of a discussion for the purposes of this, but if you do a urology rotation, I can tell you a really funny story about the FDA and the farm companies getting theirs. But it's a fantastic medicine. It'll make the PSA go to 50% of what it is. You have to multiply the PSA by 2 to know the true PSA. So if we're saying, oh, we're worried about this guy's PSA going up because it was 6, and you put him on this medicine and the next PSA is 3, and then the next one is 4, well, you know what, the next PSA is actually 8. That's a big jump. That's something that needs to get evaluated and kind of considered. So alpha blockers, that's one of our common things that we use, especially since tamsulosin is generic. Low side effect profile, doesn't need to be, it's an alpha 1A selective inhibitor, so it's going to help with relaxation of prostatic muscle and the bladder neck, muscle within the prostate and the bladder neck. It works usually within about 7 days, and if prostate is the culprit or bladder neck is the culprit, it's going to give relief of symptoms pretty rapidly with minimal side effects. Since it's 1A specific, you're going to get less of that postural hypotension associated with some of the other alpha blockers. Then postural hypotension would manifest with, I lie down, then I stand up and I get dizzy. So that's going to be rare. There'll be a little nasal congestion because it's the exact opposite of an alpha agonist like pseudoephedrine. So you can get a plugged nose, and it's going to cause retrograde ejaculation, which I have talked about in my life far more than I ever want to. Again, if there's any kind of little piece of paper I have that I could just give people, that you are still making sperm. You did ejaculate. The sperm shot up into your bladder because the path of least resistance was into your bladder because the prostate's open and the bladder neck's open. And your sperm did come out. It's not trapped in your body. That's all those bubbles that were in your urine when you peed. And you don't have to call. You don't have to call and email. You don't have to send me a threatening message that I wrecked your testicles when I examined you. Stop the medicine. It'll be fine. So it's a low risk profile, and so it's a good way for us to say, I tell patients, you don't have to be on this medicine for the rest of your life, but for me to confirm the diagnosis of obstructive prostate, this really helps me a lot. I'm not relying on my finger and your symptoms to tell what's going on inside your body. If you're responding to this, most likely the prostate's the culprit, and we can address it further, but let's just see how you respond to this. Anticholinergics, so just anticholinergics, although beta-3 agonists are also becoming popular. There's that lady walking around, her bladder keeps pulling her. Remember that little yellow bladder they showed doing like sports commercials and stuff like that? Yeah. So that's a beta-3 agonist. These are relaxing the bladder. And, overactive bladder is a little bit more commonly targeting women, therapies for that, but actually men are going to get overactive bladder in response to prostatic obstruction. So you can alleviate the obstruction. You can get them emptying better, but they're still going frequently, and they're still having those irritative symptoms. And this stuff helps. So slowing the parasympathetic pathway to the bladder or the sympathetic beta pathway to the bladder will cause relaxation, less urgency, less frequency, less urge leak, less nocturia. Risk is if they have a decompensated detrusor muscle and maybe they're still a bit obstructed, you could push them into urinary retention. So I tell them, okay, you take this medicine. If it's getting harder to pee, stop. But this is a way that maybe will get you going less frequently. Lots of side effects, tons and tons of side effects. And the cholinergic system, which is innervating like the salivary glands and the intestine, so you're slowing down that system. You're going to get constipation, dry mouth. And the beta-3 agonist, that Mirabetrix, is theoretically could raise the blood pressure, but that's not common. Herbal therapies, so I have a fair number of patients that swear by saw palmetto, and I don't discount them. There was a fairly good study, I want to say like 2009 or 2010 in the New England Journal of Medicine, looking at herbal therapies for the prostate, looking at like selenium, zinc, saw palmetto, and comparing them to placebo. Didn't find any benefit from them. So I tell patients that, but I also say I got tons of patients that do well with this, so you can consider it. I can't speak to how it works because I don't think anybody really understands. I can't speak to the purity because the FDA doesn't regulate what you're getting. I can't really tell you the dose, so they can talk to a naturopath about what they think consistently has been, a good brand or whatnot. And some people stay on that and they're very happy. The other ones, I don't know too much about them, but they can make unsubstantiated claims at 2 in the morning on channel 467. And, maybe they're right, I don't know, but like generally if something's working, I'd be happy to use it in our clinical practice. And there's always your concern that there's secondary gain for people making these unsubstantiated claims. And if it was working so well, why don't you just do a simple placebo-controlled trial and prove it? Other things that we're doing. So traditionally, if you go back to like 120 years ago, we didn't have any pharmacological therapy for these patients with obstructive symptoms, and actually, it didn't really even have latex catheters. Someone in urinary retention is going to go into renal failure, right, and then they're going to subsequently die. So it became a life or death issue. The surgical treatments were really limited. Open surgical treatment for the prostate with a poor understanding of the disease process or the anatomy led to a tremendous amount of bleeding and complication. It was around 1905 that the TURP, transurethral resection of the prostate, was first kind of promoted. And this was basically putting a rigid scope into the urethra and then using essentially different variations of resective therapy, take out that obstructing tissue. So basically putting in a scope like up to the prostate, this is the obstruction, and just cutting this stuff out like you'd core out the inside of an apple. And over time, and basically 100 years, that surgery got perfected, technology improved, but it's always had a stigma, the rotor-rooter surgery with the associated side effects and risks. And back in the day, I mean, there's about a 1 or 2% mortality from the procedure. What became very popular and has become kind of the equivalent is to use ablative therapies that are effective. Lasers, I'm primarily using laser therapy for the prostate. So this shows an example, basically putting in a scope into the bladder, into the urethra, and ablating, basically using a non-contact, or you can use contact lasers to evaporate the obstructing tissue, leaving the outer portion of the prostate intact. So, like I said, coring out the inside of an apple. This UroLift, you'll probably start getting questions from your family members because they're starting to advertise heavily and they're having very good results. Equivalent of a prostatic stent, basically delivering a device through an outpatient or office-based procedure, just basically to pull the lateral lobes aside, and that's been having nice results. The prostate's pretty spongy, so it can be pulled over. Somewhat of a game changer. We never thought of doing this before, and it got FDA approved about 2.5 years ago. One example of, let's say we do a prostate surgery. This isn't, I'm going in with a scope over here. This is not me, I got this off the web, but this same general idea. Lateral lobe hyperplasia. This is pushed apart. These lateral lobes are pushed apart because there's fluid. We're irrigating when we're doing this, so giving us a view. We turn off our irrigation, and these two lateral lobes here would just collapse on each other. And you explain to the patient, well, I can show you on the TV while I'm doing this on the flexible scope. You're voiding right through this crack. That's what the problem is. So you use that ablative therapy and open up the whole channel. What you see in the background here is the bladder, and then over time, seeing them, the tissue just re-epithelializes. The good epithelium from the bladder and the urethra comes and recovers that ablated or resected space. You get a new urethra, so you've gone through the urethral wall, you've cored out that inside thing, and it reheals, and you got this beautiful open channel. And the adenoma, that transitional zone adenoma, has been ablated or resected and likely not recurring. A lot of words on this slide. So prostatitis, it's the impact of a urinary tract infection typically. So when we talk acute prostatitis, we're thinking of a solid organ infection of the urinary system. Bit more serious than a UTI in a woman, because the UTI is just kind of a urine-based infection. This is actually in the prostate. Typically, you're going to have people that are pretty sick. Acutely, they're going to have fevers of 102, 103, feeling really unwell. It can kind of be quite progressive, usually needs an inpatient hospitalization for broad-spectrum antibiotics, and it can convert into abscesses that need surgical drainage. Typical organisms are going to be E. coli and Pseudomonas and Klebsiella, the standard UTI type of organisms. One of the adages is don't do a digital rectal exam if you think it's acute prostatitis, because if it's bad, you're going to potentiate them going into sepsis and making it worse, because you're pushing on a very infected part of the body. And I don't know if that really is the truth, but the truth is that it's going to hurt them like hell. And if you have suspicion, are you really going to change your treatment plan of broad-spectrum antibiotics? Probably not. So that's acute prostatitis. Much more common, and remember, itis is just what, inflammation, right? So much more common is going to be the diagnosis of chronic prostatitis, which is a poorly understood process. It's the best way I try to explain to patients is there may be bacteria associated with this, there may not. We're probably not going to have positive cultures. Sometimes we do. We're usually going to have to go for a long course of antibiotics, and the manifestations of the disease are going to be just irritative, just pressure, discomfort, suprapubically or perineally, urgency, lots of just unpleasant feelings of the pelvis that are classically vague. And not to say that the disease process is in their heads, it's very hard for one to feel the prostate and understand what's going on. And so the manifestations of the disease are vague, and the recovery can be waxing and waning. Some of these patients respond, like I said, to long courses of antibiotics, and then it recurs. Some people we talk about trying to find out if it's abacterial. Maybe the antibiotics will work. Other times we do things like try to find out what are the lifestyle issues, diet, stress, alcohol, sitting position, things like that that have an impact on chronic prostatitis. Unfortunately, this is a pretty common condition you'll see in primary care and in the urology world, and it's one of the less satisfying disease processes to deal with, because you can't just say, okay, I'm going to give you this, you're going to get better, we're going to move on. It's more like I said, waxing and waning. That was the low point. That was the low point of the lecture right there. Like the three phases of a story. That was our low point. Because I had to talk about prostatitis. Yeah, you had a question. Did you say first presentation? So think about acute prostatitis. It's not going to be someone showing up in the clinic typically saying, oh, I'm kind of peeing more frequently and it's burning a little bit and I'm a guy and this has never happened. Usually it's going to be, I don't feel good. I've got like a flu syndrome. I've got fevers. The urine's going to be overtly infected. They're going to be pretty unwell. And depending on how unwell they are and their comorbidities is going to be the decision to try to treat them outpatient or inpatient. I would probably empirically treat them pending the cultures with something like a quinolone, maybe double cover if I think that there's a lot of resistance, as there is now, to quinolones in this community. But if they're looking unwell, and let's say it's a diabetic or an immunocompromised or an elderly patient or something else, and I just don't feel perfectly good about it, I'm going to probably say, let's put you in the hospital, put you on some broad-spectrum IV antibiotics, get our cultures back in a day or two, and then be able to move on from there. Okay, so prostate cancer. So, fairly important topic. We're good on time. Okay, so prostate cancer. Like I said, there's a lot of controversy about PSA. Let's just kind of take this kind of straight through because this is still remains a very important disease process. So it's the most commonly diagnosed cancer in America of men. It is the second leading cause of cancer death of men in America. And this is during the PSA era. This is with us over-diagnosing and over-treating patients. Despite all of that, we're still seeing it being the second leading cause of cancer death. The majority of prostate cancers are going to be slow-growing, non-lethal. Based on autopsy studies, all men are going to get prostate cancer if they live long enough. It's a job of us as clinicians and clinician scientists and scientists to try and distinguish and find better ways to distinguish the aggressive variants of prostate cancer that require treatment versus the non-aggressive ones. And we're not there yet, but we're doing better than we were 10 years ago. 10 years ago, everybody got treated. Now about 10% of patients are getting treated with a diagnosis of prostate cancer. Risk factors, family history, classically, if there's 2 first-degree relatives, dad, granddad, brother, with prostate cancer in their 40s or 50s, that's going to put them at risk for probably a genetically associated prostate cancer, which will be a more aggressive phenotype. African Americans are going to be much more at risk as well. We know something about our diet in Western cultures is associated with the cancer, but we don't know exactly why. And this is based on twin studies and things like that with, one twin that stayed in Japan and one came over here. You see a predominance of prostate cancer here, but they're genetically identical. And we also know that the variant of the disease is going to be worse in the obese patient, but we don't have a causation exactly. So the typical 70 to 80% of the time, the malignancy, it's going to come from that peripheral zone, that zone that you're feeling with your finger. The patient's going to ask, well, I'm having all these urinary symptoms. Is it prostate cancer? The peripheral zone is typically on the outside. For it to get so invasive to cause obstruction of the urethra or invasion into the bladder, that's pretty bad disease. So that's how we distinguish BPH type symptoms from prostate cancer. They're just really different zones. It's rare to get cancers in that central zone or that transitional zone I talked about. And those transitional zone those cancers are typically a lot less aggressive. And so ideally, we want to get our diagnosis from screening, not from symptoms, right? And that's because if you wait till, someone's having some problems from this cancer, you're thinking of a T3 disease. You're thinking of this pelvic organ that is now so invaded with malignancy that you're having obstruction of the urethra, or you're getting large volume disease and less treatable disease, obviously. What is the PSA? It's a serine protease associated with semen liquefaction. And late 80s was when we got the capacity to start using this as a screening test. And it was awesome. And I think there's a slide that will talk about that over the course of the next 7 years, prostate cancer mortality dropped about 30 to 40%, and we attribute it to the capacity to catch disease based on PSA screening as opposed to relying on a digital rectal exam. And you do a digital rectal exam, 30 or 40% of the time the cancer is going to already be extraprostatic, non-curable. So we had a great kind of boon in terms of catching disease. And then the backlash was now you start catching disease on too many patients. And that prostate cancer in the 83-year-old that you caught from on PSA, that wasn't going to do anything. And it's generally a slow-growing disease at that point, so that didn't need intervention. And that's the backlash that's kind of influenced how people are saying this is a bad test. I mean, if someone has risk factors and bother, this test is really helpful instead of relying just on that digital rectal exam. So this is just showing the variety of different arguments. So the U.S. Preventive Services Task Force in 2012 came out with guideline recommendations saying don't use PSA. It's a grade D test. You have to screen a ton of patients to just catch one disease. And these were based on a couple of different studies, like a European randomized controlled study of looking at the impact of screening asymptomatic men, and a few other studies. Those, as time has gone by, have been proved to be quite flawed studies, and multiple things have come out of the further evaluation of those studies to say, actually, the non-screened men were actually screened. We missed this, but a lot of them were already screened and they were put in this population. It's a long story, but basically the results were not as dramatic as thought. And as we're seeing over time, the incidence of prostate cancer mortality or morbidity is increasing because now we're typically diagnosing when there's kind of more progressive disease because there's been a backlash against screening. I think the end result is as opposed to saying prostate cancer doesn't need evaluation, it should be, PSA shouldn't be just used as a throw-all test. It actually should be used in specific situations. Think of an at-risk patient or a population, someone between about 50 and 70 with good functional status. You expect them to live at least 10 years. This is a good test to help screen for disease. And one positive test doth not make a disease. It just says, well, we'll pay a little bit more attention to this. We have a lot of lead time with PSA before the disease gets bad. Again, this was from that USPTF Preventive Services Task Force kind of conclusion that so many patients had to be, asymptomatic men had to be screened to catch the disease, and then only one person out of those caught actually benefited. But like I said, actually I've already talked about this stuff over here. And I really want to emphasize this, that I see a wide variety of patients, and there was a misunderstanding when these guidelines came out amongst a lot of people thinking, okay, we don't have to necessarily look for prostate cancer. We already don't have time to do digital rectal exams, and we don't do PSA. There's high-risk patients out there. There's African-American men who, in their 40s will have pretty progressive disease that will progress to, fatality pretty quickly, and there's a small window to catch and cure them. There's people with a strong family history of the disease, and that's going to present in the 40s and 50s. These are people you can save their lives. Flip that and start saying, okay, the 70 and 80-year-old with multiple medical problems, prostate cancer is probably not something that we have to urgently or worry about, and even if they do have it, it's probably going to be a less aggressive phenotype. But just recognize that you don't throw out the baby with the bathwater. And so the Gleason grading system, you guys probably know this from your histology, right? You did histopathology, so it's pretty dated. This is Dr. Gleason's kind of grading scale over here. This is like not exactly space age. Actually, it is space age, so I think it comes from the 50s and 60s. But saying this is, the architectural changes for Gleason 1, 2, 3, 4, 5. The modern system, so the old system you would have the predominant histotype that's being seen, then be given a grade of 1 to 5 on a needle biopsy, and then the secondary one, and that's how you get the score. So you'd say, oh, predominantly we're seeing 3, and then we're also seeing some 4, so it's a 3 plus 4 equals 7. Modern histology, anybody who is a modern pathologist will say a needle core biopsy, if it's going to be diagnosed as cancer, is a minimum of 3. So the lowest needle biopsy prostate cancer we should have is 6, and the highest would be 10. So that's the modern scale. 90% of what we're diagnosing in America is 6. That's the one that, with PSA lead time, it's anywhere from 10 to 20 years before dying of 50% death rate from the disease. On the other hand, 8 to 10 is Gleason 8 to 10 is very aggressive, and we're thinking less than 5 years, and that's that population that I talk about that you don't want to miss. These are they will. I get calls from primary care doctors who will say, I thought we didn't have to screen for prostate cancer. Years old, and he was very active and vibrant, and he's got metastatic disease because last PSA we checked was this, and he came to see me for urinary symptoms, and now he's got widely metastatic disease. I thought I was following the guidelines. I think there's value in kind of looking at the individual also and seeing what's going on with them, and recognizing if someone's having symptoms, they're not a part of a screening population. They're actually having probably a disease that needs to be worked up. Connecticut, this is a little bit dated, this slide, but it shows you, I won't go too deep into it, but basically we know that this is showing survival patterns for Gleason disease at 20 years. So we know that the Gleason 6s, after 20 years, this dark area is showing how many are going to die of the disease. and based on their age profile. So it's anywhere about 20% without therapy. When you get into the 7 range, we're thinking about 50%. And then when we get to Gleason 8 disease, there's a high mortality rate over time. So it just gives you an idea that all prostate cancers are not the same, and it's not something to avoid entirely. What are our therapies? Like I said, 90% of what we're diagnosing nowadays, we're going with surveillance. We're monitoring the PSA, digital rectal exam, some imaging, sometimes rebiopsy, see if it's showing any aggressive characteristics, grade upstaging, going to a Gleason 7 or higher, or volume of disease increasing. These are reasons we say, let's go with definitive therapy. And what's definitive therapy? Typically external beam radiotherapy, 5 days a week for 7 weeks, 15 minutes a day for therapy, or implantation of implantation of brachytherapy seeds. These are radiated seeds that are going to become inert in the course of a couple of months, implanted as a surgical procedure, transperineally, outpatient procedure. Extirpative therapy, that's going to be surgical removal of the prostate. And ablative therapies, which are getting a little bit more popular. Metastatic disease, we don't have a good chemo, we don't have a good radiation. Chemo is purely palliative. Androgen deprivation, the only urologist in the history of the world that won a Nobel Prize for urology work was Charles Huggins from the University of Chicago, trained at the University of Michigan, and he found the androgen relationship with prostate cancer, taking off testicles of men with prostate cancer, huge reduction of the prostate cancer. You can see somebody, and now we don't have to do that, we can give an injection, LHRH agonist or an anti-testosterone medicine. You can see a PSA go from 1,000, widely metastatic disease, bones everywhere. It looks like someone's been hit with a shotgun all over their body, and within 6 weeks of giving them, let's say, a Lupron shot, an LHRH, their PSAs drop down to 1, repeat the bone scan, it's invisible. Disease is still there, it's just gotten a lot smaller, and it can really improve not survival exactly, but time to death, basically, delayed the disease considerably. And that's one of the big reasons, despite us stopping PSA screening, that we have this capacity not to see mortality rates shooting up, because we can keep people alive with advanced prostate cancer. Quality of life is not fantastic, and there's lots of complications, and it's expensive, but you're not going to see that actual death rate jump up right away. And our current therapies, so prostate's beneath the pubic symphysis, pretty difficult place to get at, even with modern kind of understanding of the anatomy, a lot of blood loss. Robotic surgery was a variation of laparoscopic approach, and urology ran with it because we found a great way to start dealing with the prostate. Instead of having instruments that were this long and we were standing upside down when we were operating on the prostate, we were able to put this robot, hold these laparoscopic instruments, and somebody else has to suffer the ergonomics while we get to sit at the console. So this is one of the cool things about urology. We love technology, and we're early adopters. And so when the robotic surgery was out and everybody's like, I do everything fine the way it was, urologists are like, ooh, technology. Yeah, I'll try that. Oh, $1 million. I'll go talk to the hospital. And so we ran with it.